These are my financial interest. So Brian Vision Institute Australia has about 5 years back published a paper saying that whole world 50% of the world is going to be myopic by 2050. So it's a epidemic, myopia epidemic we call it, coming soon, and so we are everybody is now getting prepared for that. Uh, of course, China is already leading with 80% myopia already. India is still around 9% to 27%, depending on what population you're talking about. I think myopia is very serious. If you buy a cigarette packet, it says that smoking kills, right? Because that can lead to cardiovascular disease and a stroke and other thing. Even myopia is about that serious if not controlled less than -5, and it can lead to a permanent vision loss. Up to -3 diopter, usually nothing happens. The moment the myopia increases from -3 to -5 range, the chances of early cataract and early glaucoma is there. More than -5, retinal changes, macular degeneration. Above -7, the research shows that it is 240% more chance of having a retinal detachment if it is more than -9. Now, I'm going to make a very bold statement here. Single vision glasses is equal to myopia progression. We have been prescribing without thinking, just the moment you diagnose a myopia, you prescribe glasses. So, in fact, you are also contributing to the progression of the myopia. Two things why it happens. Dr. Desai already talked about importance of UV rays. Any glass, the moment you put the glass on, UV rays are cut, and the image shell which forms with the glasses on is pushing behind, and it creates a hyperopic defocus at the peripheral retina. So peripheral retina is important for the signaling to the brain. Okay, we saw a lot of talk about the atropine and other thing. That's a pharmaceutical, but this is optical correction. Optical stimulus is more stronger because eye is an optical device. So that gives more stronger signal to the brain to increase in that direction. So the moment you correct it, you are creating a more of a hyperopic defocus. Even when the child looks at a distance, nothing happens. But the moment the child starts reading, writing anything closer, then the hyperopic defocus forms. That's why even in everybody's talking about China, so they have mandatorily created some cradles where you cannot take the reading material less than 12 inches or 16 inches. So they are forced to hold the, even same thing you can do, you can teach your parents and the children to hold the reading writing material as far as possible, so that will create a less of a hyperopic defocus. So okay, now we know that hyperopic defocus is causing myopia. What is the solution? So you need two focuses. One focus, of course, you need to see everything sharp and clear for distance. And at the same time, the second focus you want, that will create a myopic defocus on the peripheral retina, that will send signal to brain not to progress further but to shrink down. So orthokeratology has found one of the best treatments so far. I have been prescribing ortho since last 20 years, but just last 10 years we realized the ortho is also helping children, because most of the time we are giving ortho for a myopia correction for adults, those who are unfit for LASIK or those who are interested in non-surgical ways. But some children's where we have prescribed the ortho lenses, they stop progression, and we never know why this happened. And then a lot of papers started coming up about this myopic defocus, and because the reverse ortho is basically reverse geometry RGP lens. So the reverse curve gives about +6 diopters of a myopic defocus there, and that is the one which is a very strong signal to the brain. Earl Smith, one of the research scientists in Houston, he has published a lot of papers on chicken eyes, and it has proven that if you create a myopic defocus, the axial length reduces. If you create a hyperopic defocus, the axial length increases. And even in particular meridian, it can change. There are a lot of studies on animal which proves this. One of the study done on this special kind of monkey, they put one eye plus power lens and other eye normal as a comparison to the controlled eye, and other set of monkeys, 10 monkeys with a minus. So whatever monkeys they put minus glass, that eyeball axial length kept on increasing, whereas plus lens the eyeball didn't increase much compared to the normal eye. So there are a lot of 120 genes which are responsible for myopia progression, and most of the time the genes will manifest if there is a correct environment. Gene is there, but if there is no correct environment, it may not manifest. But if there is a correct, what is correct environment? A lot of activity near work, like a mobile phone, or you have seen a lot of studious students get myopia because they are spending more time reading, writing, and especially in the dim light. Again, the early rise and early this thing, the you are supposed to sleep in 2 hours after sunset, but now because of the light and everything, everybody is awake till 11 o'clock, 12 o'clock. So what happens because of that is your melatonin production is reduced, means it kicks in very late. So dopamine continues, and that is the one which continues to stimulate the axial length. So what are the options? All options has been already discussed. Spectacle option is easy, simple, but as I said, it has its own problems, UV rays cutting. But if you give bifocal, then of course certain part of the, like, superior part of the retina can be controlled, but you need 360-degree stimulus to control the whole of a eyeball. So you can go for something like a multifocal soft contact lenses or 360 bifocal lenses. Orthokeratology also has a 360 plus power. So it is a combined approach. It is not only the optical stimulus, the behavior pattern, the food, sunlight. 2.5 hours of outdoor activity is much for the delay of onset. Once the onset is happened, then it may work, may not work. But if the child spends more than 2.5 hours daylight activities, the onset is reduced. So what does signifies, if the child gets myopia at the age of say 6 years or 8 years, so another 10 years that 0.5 will keep on increasing. So addition of -5 to whatever is there. So if you can push that to say till the age of 13, and then he gets myopia, then maybe instead of -5, he will get only -2.5, something like that. So the idea is to push the onset as much as possible to the elderly age. So again, this is the same thing. The image shell is going to cause the increase or decrease in the axial length. Myopia, we are talking about axial length elongation, which is dangerous. Just a minus number along with the controlled less than 24 of axial length, nothing happens. Because if there is a stretch, like, axial length increase means what? The eyeball is under stress, the retina is under stress, and then that is going to cause, it is going to cause a narrow angle glaucoma. There is a lot of distortion in the crystalline lens, and that's how they get a early cataract at the age of 45, 55, 60. They will get cataract glaucoma, and if it is more, then of course the retinal detachments and retinal changes. This is the lens. It's still not available in India, but it is FDA approved for USA and Canada. This is by Cooper Vision. It is a 360-degree bifocal, but it has a rings, like a distance in the center, then plus power, then again distance, then again plus power. So they claim about 59% of myopia control with this type of multifocal lenses. And most of the multifocal lenses or soft lenses which are available in anywhere in the world do not have more than 2 or 2.5 diopters, whereas there are papers, or if you do a peripheral refraction, you need minimum 3.5 diopters to create a myopic defocus at the peripheral retina. And no contact lens as of now has that much high power for the reading zone. You can combine with atropine. Atropine is been proven, and it's working. And I think everybody who practices myopia control routinely prescribe atropine. There are a lot of papers that has already been discussed. There is one paper which talks about 1% atropine every 15 days or once in a month. That also works. So we came up with Dr. Maskati, myself, and Jethani. We came up with this risk score calculation. Not all myopic children are equal. Some will progress, some will not progress. Some has higher risk, some has low risk. So how to define? So we came up with some standard parameters, and we gave points for each category, like one parent myopic, both parent myopic, history of myopia, at what age the myopia started. And then you find that you add all those points. If it is less than 6, that means you just observe that child. If it is between 6 to 12, then you have to actively do something, some therapy, atropine, or some specialty glasses or something. And if it is more than 12 points, then you have to go aggressively, means increase the dosage. If okay, in India we have 0.1%, but you can always give twice a day. So some modification you can do, and actively try to control the myopia. And of course you have to measure, you have to start early. uh, the parental education is important, time outdoor is also important, close work activities. I will ask my patient not to do any close work activities after sunset. If it is must, then they have to put on a lot of lights and do the activities. Instead of that, get up early in the morning, and in the daylight they can do the near work. That will help. Food habits also can cause, there are not much of a papers on that, but it will definitely cause, because whatever the body is, because whatever food you eat. So the myocular lenses is my invention. That is a 360-degree plus power lenses with a prism to cause a myopic defocus. And monitoring actual length is the actual, you can measure, you can show to the parents this is what is happening and why they should continue. If they see the less progression, then they will continue whatever you are doing. We do the dual therapy. That means you add atropine and a optical stimulus together, so that you get a much better results. Red light therapy is now coming up slowly. Already in China, there are some instruments where child can sit for 3 minutes in front of that red light, and it works. It is already there in skin and other aesthetic situations. The red light, about 650 microns of red light, stimulates the cells and regenerates more of a mitochondria, and that's how more cells are produced, and that's how it works for regeneration. So bifocal, progressive, and DIMS lenses, uh, deep focus lenses, that can be used. Now coming to, I'm last speaker, so I'm taking a little extra time. Uh, so coming to the main topic of orthokeratology, because it works in the night. It is controlled environment. Parents are in charge. Child is at home. There is nothing can go wrong. So the child, once the child is intelligent, they can do themselves, or the parents can put the lenses in. These are reverse geometry RGP lenses, very high decay, 100, 120, 160 decay. That means good oxygen permeability, no edema or anything happens in the cornea when the child sleeps. Morning, when you remove, the child is free of any correction, sharp and clear vision in the morning. Even if the child get up in the middle of the night, still they have a clear vision. Those who are myopic, they know they have to keep that glasses next to the bed. If you get up in the middle of night, you need to search for the glasses first before you step out. So that works fantastically. How it works is basically temporarily changes the epithelium of the cornea. How much epithelium? Just 20 micron of epithelium. So total 50 micron of epithelium, only 20 micron. So it works with the hydraulic forces, push and pull. The central design, the central curvature base curve will push the lens, push the epithelium, and there is a reverse curve. Because of that space, the hydraulic forces will make that epithelium to swell. So it will change the shape, and central cells will become little thinner. And so this is a reverse curve. The peripheral curve is to alignment. The lens has to be centered properly. Then only you are going to get a perfect result. Instruments are all already you have. Only addition what you need is a topography information, because K1 K2 from autoref is only 2 data points, whereas you need more than 1,000 data points to design a lens, because it is going to sit all over. So 5 minutes more. So keratometry is already there, but topography is the addition instruments. If you don't have that, there are so many other instruments available there to get the data points on the cornea. The image capture is important. If the fluorescent pattern will give you the evaluation, but actually evaluation will be done on a pre and post topography information. Axial lens subtraction we call it. So first baseline topography, then you put the the ortho K lenses. Next morning when patient comes in, remove the lenses, do the ortho K, the topography, and do the subtractive map, and you will get this bullseye pattern. You are supposed to get the bullseye pattern. uh, that means your treatment is working. Now you know the bullseye pattern is there, but that has to be in the pupillary zone, then only it will create that myopic defocus signal. And if your lens is not fitting properly, then you will see something like smiley face, central island, frowny face. If the astigmatism is limbal to limbal, then you need a special lens called toric ortho K lenses. A normal lens may not work properly on a limbal to limbal astigmatism cases. Up to minus 3.5 diopters of astigmatism can be easily corrected with the toric lenses. So these are the different maps, nomenclature that you should get familiar with. The spherical lens looks like this on a fluorescein, and the toric will look like that. You should have a 360-degree seal off to work that hydraulic forces to work properly. So these are the different maps. If you find anything not a bullseye map, then you have to do some addition changes. You can discuss with the lab. You email the topography information, and they will do the correction and send you another lenses. All lenses are made in USA, not in India, but there are a lot of companies who can help you. There are a lot of distributors available in India who can help you design the ortho lenses. They will try to sell you the fitting set or trial set. You don't need a fitting set or trial set to do all this stuff. What you need is a K1, K2, HVID, and refraction and topography. This information you email them, and they will send you the lenses. 98% of the time, that lens will be perfect. Only 1%, you may have to do any changes. Here I want to stress more on this creating a hyperopic defocus with change of the optical zone. When we are talking about orthokeratology for myopia control, we are reducing the optical zone less than about 5.5 millimeters to cause that red zone on the peripheral retina. If it is done for the adult, then you have to go as away as possible. 6.7 is the optical zone, because we don't want any distortion when the person is driving car or in the evenings. So amount of strength, amount of plus power will decide how much control you can get. So you can combine with atropine, and this is one of the paper which talks about a controlled eye 0.4 mm 1 year elongation. If you put 0.1% atropine, then it is controlled by 0.36 microns only. So 0.05 has a more efficacy, 0.2 axial length increase. If you see ortho K, which is equivalent to 0.05, so both are almost equal. But if you combine ortho K and atropine, even 0.1% atropine, you get 0.09 action. So it is almost stop. It is not progressing at all. So this you should keep in mind. So what you need is refraction, K1, K2, HVID, and topography, and your lab will support you with the lenses. Care and maintenance is important because this is an overnight wear lens. So lens has to be sterile before it goes in the eye. That is the must. Otherwise, you may land up with other complications that can happen with any other kind of contact lenses. Disinfection with hydrogen peroxide is must. If my patients are not willing to comply with this, I will not give the lenses to them. Simple. Because anything happens, they are going to come to you. They are going to blame it on you. You only gave me this, and my eye got infected or whatever. So hydrogen peroxide system is must for this. Follow up usually you do on next day morning, then after 1 week in the evening. So you want to see how much is the holding time. The child has to see from morning till night. So in the evening you do, and you know that it is working, the holding time is there. Then after 1 month, and then after every 6 months, you keep on recording. Basically what you're doing is vision. You're taking a vision, you're doing a over refraction to find out if there is any change. uh, and of course topography is must. So, and when you do the topography, you subtract with the baseline map, the first map without on a virgin cornea. Then whatever is the day 1, day 5, day 10, or 1 month, 1 year, so you compare that topography with the first map, so you know what is happening. And if you try to do over refraction with your autoref or anything without the lens in, you are not going to get the correct information, because now you have molded that cornea. So you put that ortho K lens back, and you do the refraction to know how much it is progressed, if at all. These are the companies in the US who makes the lenses. The Wave gives you a software where you can actually design your own lenses. Most of the lenses are FDA approved for -5 diopters only. But in reality, you can do up to -8, -9. I have done up to -18 also. It's a specialized software that you can make changes, and you can tell each and every parameters to the lab, and they will design the lenses for you. So it works, and it is proven that myopia control can be achieved much in a better way if you do a combined therapy, ortho K plus atropine. It's safe, reversible at the age of 18. Once you know now that it's not going to progress further, you stop whatever treatment you are giving, like ortho K. Let it settle down. In within 3 months, the cornea will come back to its normal position. Then you measure whatever is the refraction. Then check for 1 year or 2 year. If it is stable, then you can go for LASIK, or you can continue with whatever other modes you want. Any questions? India, there is nobody who makes the lenses, but India there are distributors for Euclid. There are Euclid. They have stopped. SLR was the distributor for Euclid, but they are into some changes. Contex has a distributor in Mumbai itself at Ville Parle. I can give you the number if you want. And Delhi, the distributor will help you. There is another company, GOV. They are, I think, in Delhi also. So they also can help you with the orthokeratology lenses. GOV is there. Usually, it is +6 is what you get because of that nature of the design. But if you want to control, you can discuss with the lab and you can do it. +2 doesn't work, madam. You need minimum 3.5 diopters minimum to get a myopic defocus. And if you get say 4.5, you are creating a more force. If you get +6, you are creating more force. So you want a more force actually. Usually, as I said, it ranges between 5 to 6 diopters because of that nature of the lens, the reverse curve which you see. But if your power is less, suppose if you have say -1 and you are putting a ortho lenses, then the reverse curve may be 3.5 only. Oh, as long as you want a myopia control to happen, means till the age of like 16, 18. Yes, yes. Amazing results. The child personality changes. They go more into sports. I have a lot of patients who are into sports because the spectacle is the hindrance. But child is absolutely happy because he don't have to wear any glasses. It is under control, so nothing go when he goes out. Nothing is there in the eye, so no foreign body or anything, any complications. The parents are there to take care of everything, and except the maintenance and other stuff, it is very easy. The lens lasts for 2 years, 3 years, up to 5 years also. If there is a change of 0.75 or more, then I will ask them to change the lenses in India because it's out of pocket expense here. In the US, we do $3,600 every year. So even if the lens breaks or any changes, even the lens is good. When they come next year for follow up, we'll give them a new lens. But in India, it works otherwise. But 2 to 3 years easily, it should last. It's overnight. It works only overnight. You can see with the lenses daytime also, but it is advisable not to use during the day because then it will create a astigmatism on the cornea because it is molding. It's orthokeratology. Cornea is molding like orthodontistry. You can mold the shape of the teeth. Same way you are molding the cornea.
देखिए
It's costly. Uh, in my practice, minimum cost is 96,000 rupees. It goes till two lakh 80,000 depending on the toric lens or anything. But all other brands I told you, you get for about 30,000 rupees a pair. You can charge whatever you want is your worth. So you decide your worth. You can sell it for 40,000. You can sell it for 60,000. So, but that is also expensive for Indian population. But there are a good number of patients who are willing for that. Contact lens. Contact lenses. I think you came late. My first slide was don't put glasses. Yeah, 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 yeah. Because one thing is it will stop the ultraviolet light, so that is one of the cause, and it will create a hyperopic defocus. The moment you, I'll just show you the first slide. So because that is what the whole idea is to uh, because everybody is just the moment you design, if you know it is a myopic, you give prescription, and when you give a glasses, you're progressing, you're pushing that child into myopia progression because of can you have that slide on the thing? Yes, we're done. See though, so that is the hyperopic defocus which is coming, and you have to cause that a myopic defocus, so you need double focus. So ortho K works better, but you can use bifocal lenses, the executive bifocal, progressive addition bifocal. That is a cheaper option. Thank you. We'll talk outside.